Hello, everyone, and thank you for joining us. I'm Emily Bader, Senior Director of Investments at the Bob Woodruff Foundation. I'm pleased to see we've had such a great turnout for this event since it is such an important topic. For those of you who may be less familiar with the Bob Woodruff Foundation, our mission is to ensure that our nation's veterans, service members, and their families, those who stood before us, have stable and successful futures. Our Got Your Six network is the largest non-governmental network of organizations serving our veteran and military community. We are proud to be a funder, a leader, and a convener. More specific to today's topic, BWF funds programs that increase the availability of and access to high-quality evidence-based mental health care. A huge thank you to our panelists for taking the time to lead this discussion today. I am joined by Lindsay Eyre, Senior Behavioral Scientist with the RAND Corporation, and Brooke Fina, Associate Professor of Research with the Strong Start Training Initiative out of UT Health San Antonio. Lindsay and Brooke are both experts in their field, so I really encourage everyone joining the call to type any questions that you have in the box for the Q&A at the bottom of the screen. We're going to save plenty of time for questions at the end of the webinar. Our goal for this session is really to raise awareness about the signs and symptoms that someone may be in need of mental health care and how to identify high-quality behavioral health care providers. We all know that there's a significant shortage of licensed clinicians across the country, so a huge part of our session today is going to be talking about how community-based organizations are uniquely positioned to significantly expand the reach and effectiveness of the mental health care delivery system. So we'll begin with a short poll, and we're going to come back to that poll at the end of the session. Brooke, I think we can hand it over to you.
Excellent. Hi there, everyone. Thank you so much for having me here today and being able to talk about behavioral health care and learn more from Lindsay's presentation as well. I have just a couple of short slides to help us all think together about signs and supports for when behavioral health care is something to consider. And I want to appreciate that there is a continuum of mental health or behavioral health concerns that veterans and other individuals have. And many issues do not need behavioral health care. But my goal for this part of the conversation and the presentation today is to share some of these signs and symptoms of when behavioral health care may be indicated. What I've laid out here are some signs and symptoms of possibly needing behavioral health care. And one way to think about signs and symptoms is about the duration of them. So all of us, many of us, if not all of us, experience some of these things on a continuum. Maybe it's fleeting. Maybe it is for a couple days when there's a big stressor going on. And so many of these experiences are not uncommon to just being a human being. When we think about duration and when behavioral health care might be something to consider, one of the ways to think about this is have these symptoms been going on 2 or more weeks? I mean, it's not a direct science, but that's one way to think about it. And really importantly, are these symptoms impacting important areas of psychosocial functioning? So what I mean by that is, are these symptoms making it difficult to manage work or school or home or relationships? I won't go through all of these, but you can see this list of many. It's not exhaustive. Different changes in sleep and appetite. And again, when I say changes, what we're really talking about is some significant or dramatic shifts. So we all have a bad night's sleep sometimes, or maybe, again, when there's stress, might eat more or eat less. That's not what we're talking about. We're talking about more significant impairment. Same thing with mood changes, dramatic shifts in depression or feeling high or hyper, or lots of irritability. Behaviorally, people can withdraw, lose interest in things and people. Just a general drop in functioning, having a lot of difficulty doing kind of routine tasks or engaging with others that you're close to. Sometimes symptoms can come with problems thinking, right? Concentration, kind of thinking not like one's usual self, having thoughts or speech that are hard to make sense of or explain. Increased sensitivity, indifference, illogical thinking or disconnection, having really more exaggerated beliefs about one's ability. It's kind of, sometimes we call this magical thinking about one can and can't do when, it's not even kind of human to be able to do that or within that person's role. Kind of significant fear or nervousness or other unusual behavior that feels odd or peculiar compared to, what we typically see in someone's personality. What can we do, when we think about supporting veterans and others, of course, in pathways to behavioral health care? And I think one way to consider this is that often it's a good approach to think about how we would want to be addressed if we were having significant concerns, or how you might address a loved one if you were concerned about them. And likely many of you here listening today are in a unique position in your professional roles to kind of be a part of this identification and supporting potential behavioral health care. And I think talking to anyone, it can be difficult, but it can make a big difference. And it may require, more than one conversation. So we don't expect to have one dialogue and kind of everything be wrapped up nicely. But here are some guidances that come from SAMHSA that I really like when we frame and think about how we might support others. So being really curious and understanding, are there worries about engaging behavioral health? So, with stigma and other concerns, there might be logistical concerns, like how would I get to a behavioral health care appointment? Or be other concerns about, how can I take time away from work? Listening to those concerns, considering them, and helping the person think through it, almost like problem solving. That can be really useful. Another way to think about this is kind of to support a cost benefit analysis. Are the maybe challenges or concerns, are they bigger or smaller than the other kind of behavioral health challenges they might be going through? And is that a reason to move forward and try this on for size? They don't have to commit ultimately, even if they move in that path. Certainly being supportive, using supportive language, commenting on strengths. Lots of times people who are experiencing challenges that may require behavioral health care, don't feel great about their situation. And so I think really pointing out those strengths and what they have been able to accomplish and talking to you or anyone else can be really helpful, balancing the picture. If they don't want to talk, that's okay. Is there someone else they might be able to engage with? Showing you're listening through reflecting back what you're hearing, really thinking about what they're saying and considering how you might respond. And then another skill that can be really useful is to kind of collectively think about the conversation and try to help the person summarize it, to consider what might be the takeaways or some action steps towards moving towards considering behavioral health care. Another thing to consider is that there is a continuum of care out there, and different providers and organizations focus on different things. And it can be daunting and helpful to think about, what kind of care provider should I be looking for? And so this is not, again, exhaustive, but this would be some approaches that if you were helping someone to consider, or if you're an individual who's interested in behavioral health care, is to think about what are some quality checks when we think about quality care. So the first is, I think, fairly known that, if we're going to see a behavioral health care provider, we want them to hold a valid license from an accredited body. Usually that's on a website. We can see that pretty easily. It's really important. What we know from research across conditions is that when people engage in evidence-based practices such as cognitive behavioral therapy or motivational interviewing, that can be that is likely to achieve better outcomes. And so any opportunity to work with someone who provides evidence-based treatment is really helpful and important. So how would you know? So the website might have something about that, or also asking in some of those initial intake appointments. What types of treatment do you do? Do you know about evidence-based treatments? What are your thoughts about that? So having a direct conversation. Having an evaluation or an assessment as a part of that care. So again, that might be information that would show up on the website and also can be a part of a discussion early on with a behavioral health provider. How do we get started? And what happens? Walk me through the process. Good quality care includes psychoeducation and feedback on symptoms, and treatment planning is collaborative. So behavioral health care providers have a good set of tools and strategies to use, and we're always looking for that collaboration. And that can also be understood through discussion. Will you share feedback? How does that inform treatment options? Will there be choices? And that can depend on a lot of things: the training of the behavioral health care provider, the system, the condition that you're experiencing, etc. It's important that there's tailored treatment, and each individual's situation is unique. And that, of course, we'd want to check, do they accept my insurance? Are there other free or low cost options for me? And that, there's some consideration of involving family members or valued partners when possible. So you might ask about that ahead of time too. My family is important to me. How could we involve them in the treatment? My final slide is just to share some helpful resources. These are great organizations that provide more information about, when considering behavioral health care and how to support others who might need behavioral health care. So thanks so much. I'll pass to you, Lindsay.
Great, thank you. All right, well, I am going to build upon that and tell you a little bit about a different model of behavioral health care that I hope you will come away feeling that you could potentially implement yourselves in your organizations, and it's called task sharing. We're just going to talk briefly about what task sharing is, and I'm going to use an example from a program that we implemented across New York City recently, and we also evaluated that program, so I'll highlight some of our key findings. And then I'm hoping that we can have an interesting discussion about whether this sort of model will appeals to you or not, and if so, how you might go about designing your own program. So the program I'm going to talk about, which is based in New York City, stemmed from a recognition that there's a lot of need for mental health care, but that a lot of the people in need are not receiving treatment. So almost half of those who need it don't receive treatment. And this is not unique to New York City. This is a nationwide phenomenon. So this program was called Connections to Care, C2C. It's actually still going in New York. And the focus of it was on folks who have the greatest need and probably the most barriers in accessing care. Some of the ones that Brooke just talked about, like the costs and transportation and childcare issues, maybe lack of insurance, and of course, the waiting lists. So the folks that the program was focused on were expectant mothers and parents of young kids, out of school and out of work youth, which are known as opportunity youth, and then unemployed and underemployed adults. And I will note that we did not have veterans as a specific target population, but you could see that veterans certainly would be members of each of these populations. So C2C wanted, the goal was to bring mental health care into community-based organizations where folks who need mental health care might already be receiving other sorts of services. So in this case, there were 15 different CBOs, and they provided a whole range of different services. There were a bunch that provided job training, workforce development type services. There were a few shelters. There were some early childhood centers, some HIV testing sites, a whole range of different types of CBOs providing really important services to their communities, but not necessarily mental health services. They didn't have built-in mental health or behavioral health providers on site. So in addition to recognizing that a lot of their clients need mental health care, these organizations also recognized that often clients' mental health needs may be getting in the way of achieving other goals that their CBO had. So for example, if someone is there for job training and workforce development programming, but they're struggling with mental health concerns, they might not be able to participate in those programs and engage most effectively. And they therefore might not be able to get the jobs that they are seeking. So the way this works is that existing staff at the CBOs were trained by their local mental health provider partners in several evidence-based mental health strategies. So this is bringing evidence-based mental health strategies into these existing CBOs to be delivered by staff that are already trusted, that understand the culture and the community that they're working within. They understand their clients and their various needs already. They don't necessarily carry the same stigma as going to seek a specialty behavioral health provider might. And in this particular C2C program, those CBO staff were trained in how to do mental health screening, for example, depression screening, psychoeducation, which is basically teaching people about what it means to have all these symptoms together and what are the available treatments that you might be able to consider, different supports that could help you to improve your well-being. Motivational interviewing is a non-judgmental, client-centered approach to talking with somebody about their challenges and trying to increase their motivation to change. It was developed initially for drug and alcohol abuse, but has been used for a lot of different problems. And then mental health first aid is one that some of you might have heard of before. That's a training where in this case, CBO staff were trained to recognize those signs and symptoms of mental health and including substance use problems that Brooke talked about earlier, and to know what to do when they see those symptoms, know how to respond. So I'm just going to briefly highlight some of our findings that show the impact of this particular program, and then point you to some resources for learning more. So one important question you might be wondering about is, how feasible is this really? We are very busy as a CBO. We have all kinds of demands on our time. Is this really feasible to take on even more work to address mental health concerns? And we found evidence that it was feasible. It was not always easy or smooth in the transition to this program, but by the end of 4 years working on this, we had almost 1,800 staff at the CBOs who had been trained in the different C2C components I mentioned earlier. We had over 41,000 clients who had received mental health support through the program. And importantly, we know that often when folks are referred for mental health care, they don't always show up, or they encounter so many barriers that it's just really hard to actually get there and engage in treatment. And so we found that compared to the start of the program in year one, where only about 62% of our clients were keeping mental health referrals. By the end of the program, we had 83% doing so. And then we also had a component of our evaluation where we looked over the course of 1 year and we compared individuals who got C2C to clients in getting help from similar CBOs, but who were not getting C2C. And we found that those who got C2C, who were in this youth category, were much more likely than their comparison group counterparts to get outpatient mental health services, and much less likely to use the emergency department for such problems. So this suggests that, for one, C2C participants may have been getting help earlier, so that support from their CBO staff through C2C was maybe helping to address problems before they became crises. And that also perhaps that engagement with somebody who they trust and they already know helped sort of ease the transition to outpatient mental health services when they needed it. Then we also found that the C2C group had greater improvements in depression and psychological distress relative to the comparison group of these opportunity youth. In terms of our adult population that we were focused on, we found that the C2C group had greater decreases in alcohol use and misuse, and also, interestingly, greater increases in their weekly work hours and their monthly pay. So those folks these were mostly under and unemployed folks who were job seekers, and compared to other folks in the same boat who didn't get C2C, these individuals were working more and being paid better for that work. So just a few key takeaways. So we found again, that was just a glimpse of our findings, but taken together, we feel confident in saying that this type of program is feasible and promising for helping both youth and adults in getting mental health care. We also found that, in general, the CBO staff and mental health providers who were involved in the project liked what they were doing and felt like it was mutually beneficial. The mental health providers really liked getting to know more about the amazing services provided by these CBOs that they weren't necessarily aware of before. And they loved just being able to work together to address a whole, in more of a whole person way, clients' needs. And then we also importantly found that there weren't necessarily universal changes that were all the same for everybody. So we did find some evidence that C2C helped certain populations and worked better in some settings more than others. So if you'd like to learn more, the document on the right is the evaluation final report. If you're a data nerd or you just want to get a little more information about the study, that's that document. The document on the left, the Helpers in Plain Sight, is actually a toolkit and guide that has some interactive worksheets. Both of these documents you can access online. The one on the left is, I think, maybe a helpful resource for anyone who's interested in exploring how they might design a task sharing program for their organization and what sorts of decisions and considerations they might make. And you can find both those documents at this link here. And you can also email me if you have any questions.
You mentioned the interconnectedness of what a veteran may be going through and how, if they have some underlying mental health needs that may impact their progress in employment or other goals that they may be seeking. I imagine that the model of task sharing is going to be really encouraging for a lot of the organizations that are on here today and have been in situations in the past where they've had a client for something unrelated to mental health, and they've really felt like that client needed some type of mental health intervention. Can you talk just a little bit more about that space in between, like just before they need clinical care, and that space that can really empower people to know that they can take on that role and it doesn't have to be a clinician?
I would say a couple things about that, and I'd be curious about Brooke's feedback as well. for one thing, there's evidence that not every mental health concern requires a full course of therapy or medication. There's often, especially when caught early, there's often great improvement seen when we reach out to supportive others in our lives who can interact with us in the ways that Brooke mentioned earlier. And sometimes that support is even better than going to see a therapist. I'm a clinical psychologist, so I feel like I'm dissing myself in a way, but in part because of the cultural competency and the trust that a lot of folks have in those just community members who don't carry the same stigma. And sometimes those kinds of feedback and questions about issues that can feel very personal and some people feel a lot of shame about, sometimes those topics can be broached more easily and more comfortably with someone that they already know and trust and feel understands them.
And on that note of kind of that connection with someone who is pre-existing, they already know them, there's a little bit of trust building. Can you guys talk a little bit about just how to broach that conversation? I think, Brooke, you touched on that a little bit, but for everyone listening, I'd love to be able to provide some more strategies you both have seen that are successful to really encourage people to take that step and seek care.
That's a great question. I mean, I think the first priority always is to listen and to hear what's going on. I mentioned, actively listening, being curious, asking curious questions. When we listen, it really shows behaviorally how much we care about people. And in our busy lives, it can be easy to go from one thing to another and, have a phone on your side. And so putting those distractions away and saying, I really want to hear what's going on with you. Can you tell me how you're doing? Can we go get coffee? Can we go get a sandwich? Can we take a walk? I think like that is a first step in opening up the dialogue. And the other thing I would say, and again, I'm not as familiar with the task sharing as Lindsay is, but like, also not coming in with any preconceived notions. I mean, we don't know how that conversation will go, and maybe you'll learn something that really makes you think, okay, I think in my role, it would be helpful to get them, thinking about mental health or behavioral health care. Maybe you learn something different and that they need some help, like sorting through social support or, other type of support or problem solving. So I think those are some things to consider in engagement.
I'm curious if there are any other resources. I know you shared some on the slides, but where individuals can find trainings for motivational interviewing or mental health first aid?
Yeah, so in the Helpers in Plain Sight guide, there is some of that. I would say some of those approaches are going to be much more time intensive for training, like motivational interviewing is pretty time intensive to get fully trained. On the other hand, something like mental health first aid, I would say, is not only more accessible, but cheaper, more, cost less. It's also, a lighter touch sort of approach. So I think it kind of, I recommend folks think about what their clients need, what would be feasible for their organization, and then explore different options. But that toolkit, and then I think also some of the links Brooke provided would also have some helpful information about where to find those trainings.
And I know the training you provided was not veteran specific, the program you launched, C2C in New York City. And of course, we know there are a lot of veterans who are using VA. Of course, that is free and an excellent resource to a lot of veterans. But I think for this session, of course, we're talking about those who may be opting not to use VA or maybe ineligible. I'm curious if you all have any thoughts on the value of a peer-to-peer connection to making, that encouragement to seek care even more effective when it's coming from a peer.
I mean, I think what you mentioned about the cultural piece, there is data across different types of interactions that say like a trusted messenger is really important in the interaction. And that makes sense. I mean, think about, as people, who do we go to when we need something? You know, our authorities or our connections are often people in our community, people in our sphere, right? Because they're trusted messengers to help. And so I think like that is, it makes tons of sense that would be across, you know, many domains, that you know, people who are peers get it, know me, understand the circumstance, and that's really important. And then I think it's thinking about, as a, you know, in the systems that we work in and live in, it's like, how do we support those peers in equipping them in really having the information at their fingertips that they need, or being able to source information that they need to be that peer ally.
And I think there's definitely value in having somebody who has lived experience with the mental health concerns and navigating the different decisions involved in seeking help and getting into recovery is really important. I would just also like to note that one question is, who delivers that support? Like, is it a peer support specialist? Is it a CBO staff member who's not necessarily a peer specialist? Is it a behavioral health, you know, licensed mental health provider? But then there's also the question of where. And what I want to really emphasize is that support does not have to happen within the walls of a VA hospital or a mental health clinic. It can happen at a library. It can happen at a grocery store. It can be anywhere in the community where people feel comfortable. And we actually have a project right now where we're delivering peer support in public libraries in Texas. And and a lot of those communities are serving a lot of veterans. And it's been kind of amazing to see the response. That it's, you know, you wouldn't necessarily walk into a library and think that you're going to be able to talk to someone about your mental health needs, but it turns out it's a pretty good fit so far.
I love how innovative that program is, because I think you're catching people who wouldn't typically be walking into the door of a VA, and you're bringing the resources to them. On the note of peers, and even someone who's not necessarily a trained peer, but who is that trusted messenger, how do you teach people not to go in too much with their personal experience?
In our project in Texas, where we're working with a peer support model, we have an organization we're working with that's what they do, is train peer support specialists. They do the training and certification of those individuals. And so they have a lot of experience in that. And I know probably a lot of the organizations on this webinar also are similarly experienced. So I really do recommend getting, whether it's training as a peer or for your CBO staff, getting that training from experts who have done trainings before and who understand all of those issues and can prepare people for that role.
I'm curious, Lindsay, for those who are listening who may be on the mental health side of this, was there any feedback from your implementation of C2C in New York that you heard from the CBOs about how mental health care providers can better equip them in this effort?
What we learned was, it was interesting, actually, that in many ways, the mental health providers were more reluctant or I guess a little more wary of this model than the CBOs were, which was not necessarily what we would expect. But I think it really helped when the mental health providers met in person with the CBOs, went and learned about, you know, and vice versa, like mutual learning, like in person, regular communication about what are the strengths and challenges of each organization and how they can best work together.
And Brooke, I know you all at the Training Initiative have trained thousands of providers now in evidence-based treatment, of course, specifically for PTSD, but I'm curious if there's attendees who are joining today who are interested in, starting this task sharing model, or even in just finding qualified organizations that have those credentials and they've gone through the screen that you've mentioned, where can they find like a list of that? Where can they go to even get started on building partnerships with behavioral healthcare providers?
Yeah, so I mean, unfortunately, there is a bit of trial and error and talking to different organizations, and at the same time, that builds community and connection. And I think there's some real benefits in connecting CBOs and local behavioral health or mental health organizations. So I think like doing some cold calling for better or worse can be helpful. And, thinking about also who's coming through your organization and maybe what kinds of needs you're aware of, mental health needs that you're aware of. I mean, that might help to formulate the discussion and the questions more. On our website, strongstartraining.org, we have a list of providers across the country who've been trained by us in evidence-based treatments for PTSD and some related conditions. And while that's not exhaustive of all the behavioral health providers, that is another place you could go if you are looking to learn if there are, local providers or organizations that are trained in treating PTSD with evidence-based treatments.
And I think, Brooke, a majority of them have experience working with veterans or service members, right?
Yes, I should mention that. That is our focus is really supporting the community behavioral health workforce who supports veterans and veteran family members in seeking care in community settings.
I would love to kind of shift to a couple of questions from the Q&A. Before I do, Lindsay and Brooke, anything else that you want to make sure that people take away about kind of the signs of when somebody may be in need of care, or how to get started implementing task sharing in their community? I will actually start with the first question from the Q&A, which I was very tempted, Brooke, to interrupt you in your presentation to ask you to speak to this, because I think it is such an important question. Can you define behavioral health?
Yes and no. I will try certainly for the group. I think like behavioral health and mental health are terms that are closely related. They are slightly different conceptual scopes. When we think about mental health, that typically focuses on a person's psychological, emotional, and social well-being. And when we think about behavioral health, it focuses more specifically on the connection between behaviors and health and well-being. So it really kind of includes more like actions and habits and things to do. So in like a mental health / behavioral health context, often people use the term behavioral health when they're focused on models of treatment that are about doing things differently. And mental health is really kind of more about thinking about or understanding, right, kind of other psychological factors. And at the same time, they're really used interchangeably in many places. So it's a great question.
One thing just related to that is that there's an unfortunate siloing of mental health care and substance use, addiction treatment. And so I think the term behavioral health is a bit more inclusive to include everything, whereas often, and I use the term mental health to encompass both in my talk, but often behavioral health is sort of the more inclusive term.
Another good one, how important is cultural competency as a quality trait in these efforts? I think we talked a little bit about this, but I'm not sure if there's any data that you all can share, whether it's in formal clinical work or in more informal peer support.
Familiar with I don't have the data at my tips. That's not an area that I know well. Unfortunately, there's been, documentation research over the years where there's kind of a lack of cultural competence or cultural humility when it comes to supporting veterans with PTSD. And I think like I really appreciate the term cultural humility because I think it really helps us to recognize one's own limitations of cultural knowledge and like kind of respecting other cultures and coming and saying, this is the things I don't know. I think for clinicians, there's a strong focus in supporting better cultural humility and competence. I think we've seen that in particular in the last half a decade. And so that's a value, I would say, that's shared across disciplines. How it's executed at times, it can be, challenging for different reasons. One thing with, working with veterans, I think what gets a little bit tricky with clinical care is when we kind of support the assumption that you have to be one to know one. And I think a good analogy is, if I was I don't need, if I'm doing CPR, right, on someone, like I don't need to have and that person needs to go on to be, surgery. Like I don't also need to be a surgeon. And so I think that we want to open the aperture of available providers. There's already a dearth of available providers to be able to kind of support veterans, even if you're not prior service or not a veteran or not active duty. And I think that's an important piece of this.
Another really good question. Are there any evidence-based treatments that help veterans deal with triggers in real time?
Yes, would be, my kind of blanket unhelpful answer. But we have really good evidence-based treatments across, to support and reduce or eliminate symptoms across different conditions. So PTSD, for example, evidence-based treatments for PTSD are really focused on helping people to approach those triggers, work through them, make sense of them so that they become, less concerning over time. And there's a really strong focus in, processing through trauma and what happened to help people in the here and now and with triggers that they're currently experiencing. That's much of what evidence-based treatment for PTSD is about.
One thing that we did not mention that is an incredible resource is crisis response planning. I would love for us to touch on that a little bit. I don't know, Brooke, if you want to speak to that.
Crisis response planning, or also known as safety planning in the VA, is a one encounter intervention to support people who are, going through suicide-related distress. So people who are, at elevated distress and have, risk for kind of getting into crisis and suicidal crisis as well. And it's a pretty simple intervention. It's basically a checklist of strategies that are predetermined and pre-developed. The data that supports both those interventions have been done in clinical settings, but I can share that anecdotally, and what happens, across different organizations is that many peers and other community members are doing crisis response plans or safety plans. I think that it is with the, without the data, conceptually it makes sense, and it's a great peer-to-peer intervention to consider. So I yeah, certainly recommend looking into it. And we are supporting some CRP trainings. If you go to our website again, for veteran serving organizations, for peers and clinicians.
Can you say one more sentence about that? Because I think people will be really interested just about that training. Is that free? Is that open? Is that application open now?
Yeah, so it's no cost training. It's supported by an initiative called Face the Fight, and that is really focused on suicide prevention for veterans. And so there are monthly 5-hour trainings that mostly myself puts on, and the goals are really to help the individuals who come, who support veterans, to be able to actually do CRPs at the end. So it's more than just awareness building, but the goal is really skill building at the end of that training.
We had another question about training, specifically screening for mental health needs. So maybe a screening for depression. Any recommendations on if they're training specifically for screenings?
I don't have those off the top of my head, but they are in the Helpers in Plain Sight manual, and maybe we can follow up with some of those resources. I guess I want to emphasize that it's not rocket science. And so the most important thing is sort of the skills that Brooke was talking about earlier, that when you're doing a screening, you want to be approaching those questions, thinking about your tone of voice and your eye contact and what you're conveying to the person so that they know that it's okay and it's safe to disclose how, sometimes scary feelings they might be having. So I would love to follow up with some links after this.
Helpers in Plain Sight also has a wide variety of resources for those of you who may be considering implementing task sharing. So definitely check that out. I think we had one more. Oh, this is probably not a brief answer. Does the VA cover treatment, or is it through private insurance? Do either of you want to take this one?
Probably not the best person to talk about like VA benefits. I don't have that information kind of, well thought out in my head. So yeah, I don't think.
I think the short answer, I'm not sure what the person's background who asked, but I think the short answer is it depends. A lot of veterans are eligible for behavioral health care through VA. Are those who may not be eligible, or who may opt not to use VA either because of access issues. So maybe they're going through a community-based provider because they don't have access to VA either physically or technologically. But I think the short answer is it depends.
I guess the thing I will say is that, VA also has developed partnerships with community organizations for individuals who, for whatever reasons, are not interested or don't want to or can't access VA, that VA, some VA benefits can be used with those for behavioral health care.
Is there anything you all would like to say about post-traumatic growth?
Post-traumatic growth is, people define it in very different ways. And so it's a little bit hard to answer and even to measure. Sometimes we can think about post-traumatic growth as people who successfully go through PTSD treatment and are living their lives again in a meaningful way that is connected to the people they care about and their values. And that's post-traumatic growth. And I can't imagine that doesn't reinforce, the lessons learned and, the motivation to continue to kind of do the strategies and the things that are most helpful to people. Lindsay, I don't know if you have any other thoughts about that.
There's that scenario for post-traumatic growth, and there are also folks who find that after experiencing some sort of trauma that they do better. And so, they find certain strength and resilience in that experience that helps them grow as a person. So that's another way that some people talk about post-traumatic growth.
I know we're coming up on the end of our time. Thank you both so much. I think, again, I said this when I opened the question section of this webinar, but I really think it's probably empowering for so many people who are attending, who are interacting with veterans every single day, to hear that there are really tangible ways that they can provide low barrier initial mental health care, and really start that conversation with individuals who maybe just need a little bit of mental health first aid or motivational interviewing, and don't necessarily need to engage with a clinician. And then also empowering them to build relationships with mental health clinicians in their community to be able to make those referrals when they are necessary. So I think, again, for those of you who are interested in implementing task sharing, we've dropped the link to Lindsay's paper in the chat. And for those of you who are interested in joining our next webinar, you can join us on December 5th. It's going to be about protecting veterans from scams and fraud. So thank you, Brooke and Lindsay, again, and thank you all for joining and being interested in learning more about this topic. We will share the slides and the recording.
Thank you.
Have a great day, everyone.